Hello, my name is Dr. Pavan Randev and I am one of the cancer leads in the East Midlands Cancer Alliance. This is a presentation about diabetes and cancer risk. This project has been set up by myself and Professor Laura Ashley of Leeds Beckett University. We're going to run through the known complications of type 2 diabetes that you're all probably aware of, and some information about the current causes of death, of mortality in diabetes. Then we'll run through screening programs and the opportunity that this presents. Just as a reminder, diabetes type 2 is a condition that affects the most deprived, and this data from Diabetes UK confirms that. However, when we think about the long-term complications of diabetes and we think about what the leading cause of death is nowadays in type 2 diabetes, it's no longer cardiovascular and stroke. We have shown over the last 20 years that actually cancer rates are rising, and that compared with the general population, if you have type 2 diabetes, you have a greater risk of certain cancers. This was originally shown in 2019 in Scotland and has been followed up since then, and has now been shown by Professor Melanie Davies, who's a professor of diabetes in Leicester, that cancer is predicted to be the leading cause of diabetes-related deaths, overtaking cardiovascular disease. In her paper, Melanie also highlighted that now is the right time to widen prevention efforts and to reduce cancer incidence, and that early cancer detection could reduce that number of avoidable deaths. When we think about the diabetes-related cancers, there are 6 of them that come to the forefront, but of those, only 2 have screening programs, breast and bowel, and those are the cancers that I'm going to focus on for the rest of the presentation. The underlying issue with type 2 diabetes is insulin resistance, and when we look across the board at insulin resistance related cancers, on the left hand side you can see colorectal is at 1.3 to 1.4. On the far right, breast is around 1.2. So there is an increased relative risk for both types of cancers. Bear in mind that for colorectal, we diagnose around 40,000 new colorectal cancers a year, and for breast, it's around 59,000 new cancers diagnosed annually. So we are talking large volumes of patients. Remember that this applies just to type 2 diabetes. In type 1 diabetes, in fact, your cancer risk is slightly lower. When we think about insulin resistance related cancers, as highlighted a couple of slides ago, one of those is early onset colorectal cancer. And early onset in this setting means below the age of 50. And this paper from the BMJ last year showed that the current theories are around insulin resistance, sedentary behavior, high fasting plasma insulin levels. So as well as the conventional over 50s, 60s and 70s that we see with colorectal cancer, we are getting greater numbers of early onset cancers. Work has been going on in Manchester to try and find out if this is related to the obesity linked to type 2 diabetes or whether it's the diabetes itself. To be honest, it doesn't matter too much, because for us in clinical practice, both things go together generally. Laura Ashley in Leeds did some work trying to find out whether this risk was known of. She asked over 300 patients with type 2 diabetes, did you know that type 2 diabetes is a risk factor for breast and colorectal cancer? And just over 1.5% actually knew that there was any increased risk, and no one realised that it involved breast or bowel cancer. This information isn't generally available on diabetes information websites, and Laura's second study highlighted that very few included cancer screening or protective behaviours. However, things get a little bit worse than that, because it turns out that if you have diabetes, you're less likely to do your bowel screen. And this paper is a little bit older, but it applies to an English population, around a 13% reduction in uptake. This isn't only a UK issue, and in fact, in Denmark, Tine Lauberg found that for these people, for people with diabetes, that in fact there was a 10% difference. Apologies for moving on quickly. Are there any other ways of looking at this? Well, yes, if we screened everybody at the same level of bowel cancer risk, we would be actually starting bowel cancer screening 4 years earlier, which we don't do. When we look at breast screening and cervical screening, these two have lower rates of uptake, and this is across the board. The final paper that Laura has produced asked doctors, nurses in primary care and also in secondary care whether they were aware that type 2 diabetes is a risk factor. The great majority of GPs and of practice nurses did not know that type 2 diabetes is an additional risk factor. When you go for breast screening, at the moment you're invited every 3 years between the ages of 50 and 71, and women will automatically be invited. They'll be given an appointment, asked to attend the appointment. For bowel cancer, a kit is sent out in the post, and on this slide it's slightly out of date because the age range has now changed to being from 50 to 74. And one of the things that we know, if you look at the star on the right, is that the bowel cancer program works brilliantly to prevent bowel cancer by detecting high-risk polyps, removing them, and then that individual no longer will get bowel cancer because they go into a surveillance program every 2 years. The difference between picking up bowel cancer and picking up high-risk polyps is highlighted in the 23-24 data from the national program. The whole program, if you look at the red arrows here, led to 35,000 colonoscopies, leading to at least one high-risk polyp, but only 5,000 bowel cancers. So we have a 6-to-1 ratio of people benefiting from the prevention aspect. Therefore, it's really important that everyone in the general population takes up bowel screening, but if you have diabetes, you're going to get an even greater benefit. So what's the opportunity for us within primary care as GPs, practice nurses and healthcare assistants? What we have devised is a way of using the annual diabetes review, because once a year at least we will be seeing our patients with diabetes as part of QOF review. I have added a question about screening uptake on the Ardens template, and I'll show you this in a couple of slides' time. And if our patient over the age of 50 has declined screening for breast or bowel, you can share advice with them. And this advice can be in the form of an informational video link, and we will be setting up Accurx templates, and you have the option of setting them up as you wish within your practice. And we've also attached a code to it. Emily Wong undertook an audit of diabetes non-responders to the bowel screen. And she asked 82 people in this situation whether they'd received the kit, if they'd been screened before, and why they didn't opt for bowel screening this time. What she found was that the biggest proportion of people who didn't take part in the bowel screen actually had just plain forgotten. And that when they were told that there was an increased risk and that it was up to them to order another kit, they then said, oh yeah, we will ring the number. Emily gave them the number, and we will then order another kit. So because bowel screening is convenient, it gets forgotten about, and the lack of a deadline to return the kit means that people just put it off. Now, the change that we've made is that in the diabetes template in Ardens, on the review plan tab, we have added one extra item, which is advice about cancer. So when you see your patient in the surgery and are doing their diabetes check, if you go to review plan and you ask about whether they have completed their breast or bowel, depending on the sex, of course, then you can tick that box to say that you've given the advice. Within Ardens, that allows you to go on to the cancer screening templates. And if you have time or wish to, you can then document in the breast, bowel and cervical screens particular types of information you've given them. And in fact, for those, you also can access a printable leaflet. In Leicester, where we piloted this as well, we added to the Leicester diabetes template cancer screening advice as well. Now, if you wanted, you can also share with your patients a set of sample screening videos, and within this slide set and the PDFs that accompanies it, you can just click onto these boxes and it will take you through to the slide. Because this project was looking in Leicester initially, we created videos in Urdu and Gujarati, and we have access to a Hindi video. We do also have the ability now within the Cancer Alliance to translate videos into a number of other languages, so that if your primary care network or practice wishes to highlight a particular population, for example, an Eastern European population, we can create those resources for you and with you. We also have sample breast screening videos, and Kelly from Leicester, who's one of our breast surgeons, has created the video at the top. Underneath there's a further video in Urdu. Again, you may already have within your organisations ways of accessing videos like this that your ICB has created. If so, please link to them. I just wanted now to highlight something that you may not have been aware of, which is that a comparison of the bowel screening programs across the United Kingdom. And you can see, if you look at the row on the left-hand side, on the column on the left-hand side, that in England we're screening from the ages of 50 to 74 for bowel screening every 2 years. Now, importantly, the threshold of positive risk has changed. So it's changed now from 120 micrograms, and it's going to go down to 80 micrograms at the end of the year. There is a particular importance of this for Derbyshire, because Derbyshire was the very first area in the country, in South Derbyshire, to nationally roll out the Fit at 80. And as a result, over the first 6 months of that programme in 2025, they've been seeing a third more patients coming through, removing 37% more high-risk polyps and diagnosing a quarter more cancers. So what this means is that that shift has already paid dividends for everybody in your population. But if you have diabetes, you are more likely to be in one of these categories. So if you're diabetic, you will benefit even more from this. Now, I did ask one of the healthcare assistants who has been piloting this in a practice in South Derbyshire, how did you get on with this? And this practice has been doing this project, talking to patients, reminding them over the last year. And her feedback was, she said it was all quite positive. One of her colleagues really likes it and feels that it's something that feels so important to her that she's an enthusiast for it. And then she also highlights that, look, everybody needs to remind, because everyone forgets all the time. It's easy to forget. And then people, once you remind them, they say, okay, we'll have the number. We will then go on. And because you occupy such an important place in this person's health, you've been seeing them every year, possibly for a number of years, they trust you to look after their diabetes, and they trust you to give them good information. And so this project builds upon the relationship that you have already developed using your own skills already to build up that level of trust. Always remember that if you have new onset diabetes, which is type 2 and presents with weight loss, a small number of those may have a pancreatic cancer. The same applies to somebody who has established diabetes and all of a sudden their control has gone way off, but they're losing weight. Please remember that that patient needs referral into your GPs to consider whether further investigations, possibly CT scan, possibly ultrasound, are necessary to exclude pancreatic cancer. Fortunately, this is a relatively rare diagnosis. If you have any questions about this presentation or you want to connect with me, on the very first slide I've got my email address, which is pawan.randev@nhs.net. Please connect with me if you want to have any further information. You should also have been sent the PDF of this talk as well. If you haven't or would like to have it, please get in touch with me and I'll be very happy to send it out to you. Thank you for listening, and I hope that this has been useful for your clinical practice and that you are able to help your patients to lead a better life, and a life where hopefully for some of them their bowel cancers and their breast cancers will be prevented or picked up at an early stage. Thank you for your attention.